Are we on? Hello, Gertrude and Beverly.
Hi.
Just giving 1 more minute for the rest to join, then we can start.
Okay.
You have start joining.
Can't wait to see what you got on, Rachel.
Okay. Are we ready? Can we start? Is everyone ready? Beverly, your speaker is off. Okay. Okay. So today we are going to continue with the renal system. I had explained to you the anatomy and physiology of the renal system. I'm going to share the document here and you see the picture, but I'm not going to go into it today. And please let me know if you have a question. If you don't understand, just let me know. Okay, can we see my screen?
Yes, please.
Can everybody see my screen? Today we are continuing, like I said. I had given you the renal system. I told you the renal system.
All right then, thank you.
You have a question?
Hang on. I didn't know you started patient.
Okay. Okay, so I had told you that the renal system has 2 kidneys. Every human being has 2 kidneys. We have the left and the right kidney, and we have the 2 main arteries, 2 main vein, 1 vein and 1 artery. So the vein is the one that carries deoxygenated blood, and it carries the blood to the heart. And the artery is the one that brings the blood from the, okay, so the artery brings the blood from the heart with waste material, and the vein carries the blood to the heart after the oxygen in it has been consumed. It sends it back to the heart. So the artery will bring it out of the heart to the kidney and to other body supplies. So when the artery brings the blood, it drops it in the glomerulus, which is where the Bowman capsule 2 is, and then it does the filtration. So the filtration goes through a process, and that process is goes through 3 processes. So it does, the first one is the filtration process, the second one is the reabsorption, and then the third one is the urine that is that comes out. So besides that, we have the anatomy. Each person has 2 kidneys and are enclosed in the renal capsule. The renal cortex is the outer layer of the renal capsule, which contains blood filtering mechanisms, which is the glomerulus. You can see it when the diagram is minimized. In the other diagram, I know you guys had seen it before. So we have the nephrons, which are the functional units of the kidneys. It is located in the parenchyma. In the parenchyma, composed of the glomerulus and tubules that selectively secrete and reabsorbs ions and filtrates, which include fluid and waste electrolyte acid-base balances. That's the work of the nephrons. It does the balancing factor in the kidney. It does filtration and reabsorption. So the nephrons, like I said already, is the functional unit of the kidney, is the main thing that make the kidney work appropriately. Glomerulus, and each nephron contains the glomerulus capillaries, and they do the filtering. It's a meshy tissue like a net that does the filtering. So we also have the Bowman's capsule, which is the one that make it look like a curve where the glomerulus is. Can we see my screen?
Yes.
So from the glomerulus, we also have the renal tubules. So the renal tubules are the two wings that forms like a U shape, and it goes to connect to the bladder. So the renal tubules are the long ones that go down, and that's where it goes to the renal pelvis of the kidneys, and it connects from the pelvis of the kidneys down to the urinary bladder. So now the main functions of the kidney is to maintain acid-base balance. So this you need to know what the kidney is supposed to do in your body. Is to help maintain acid-base balance, is to excrete end waste product of metabolism, is to control fluid and electrolyte balances, is also to excrete bacteria toxins, water-soluble medications, and medication metabolites. And it secretes renin to regulate blood pressure, and erythropoietin to stimulate the bone marrow to produce red blood cells. So the kidney does stimulate erythropoietin, which will help in the bone marrow to regulate red blood cells or to produce more red blood cells. And it helps produce renin. It's an enzyme. Renin is an enzyme which helps to regulate your blood pressure. Now we have this, it also synthesizes vitamin D for calcium absorption and regulation of parathyroid hormone. Now I finished the urine production. I had explained it. Let me just read this out. As fluid flow through the tubules, water, electrolyte, and solutes are reabsorbed, and other solutes such as creatinine, hydrogen ions, and potassium are secreted. Water and solutes that are not reabsorbed become urine. So those that are not reabsorbed in the process when the blood is passing through the renal capsule or the glomerulus and the Bowman capsule, when it's passing, those that are not absorbed are excreted. The process of selective reabsorption determines the amount of water and solutes to be secreted. So selective reabsorption is after it has finished the main filtering. The selective reabsorption is the one that will do the final absorption before pass out the urine. Now, I did show you a picture where you have a muscle that tells your brain that your bladder is full and you have the urge to go and pee. And then another muscle controls the opening of your bladder. So your bladder sphincter will open. When you get to the bathroom and you are ready to pee, it tells your mind it's time to open up. So for people who have problem with urinary system, or for people who have urine incontinence, that means that muscle does not work well. There's a problem with that muscle that controls the opening and closure of the bladder. So it doesn't signal the brain to do its job. Now, of sodium. So when the amount of sodium that is excreted, when the amount of sodium increases, extra water is retained to preserve osmotic pressure. And an increase in sodium and water produces an increase in blood volume pressure. So when we know that sodium will cause water retention, which will further increase your blood pressure. So this will again call for the enzyme renin to help in regulating your blood pressure. So there will be reabsorption of sodium in the distal convoluted tubules. This reabsorption is controlled by the renin enzyme that helps to regulate the blood pressure. So renin is a catalyst, and it catalyzes the splitting of angiotensin 1 from angiotensin. It catalyzes the splitting of angiotensinogen 1 from angiotensin. So it starts from angiotensin to angiotensin 1. That's what the renin is supposed to do. That's the process of converting it to be able to control that volume that you have. So from angiotensin 1 to angiotensin 2. So this is a strict process that has to do with its own anatomy. For the sake of the enclaves, just understand that renin serves as a catalyst and it helps to split angiotensin to angiotensin 1. And then from angiotensin 1, it goes to angiotensin 2, which is a potent vasoconstrictor and it stimulates the secretion of aldosterone. Aldosterone is a hormone. So aldosterone will stimulate the distal convoluted tubules to reabsorb sodium secretion. So this has to do with how the kidneys absorb sodium. So for patients who have fluid overload, that is an indication that the kidneys isn't doing its job. Yes, of course. So patients who have fluid overload, it means the fluid, they have fluid retention, sodium not being it's not being excreted, it's not being absorbed well. So the enzyme that is supposed to regulate the blood pressure and regulate the hormone, that is the renin, that is supposed to start all the process, that is supposed to catalyze, supposed to notify angiotensinogen that it is time to secrete and it is time to convert angiotensin 1 to angiotensin 2 as blood flow through the lungs. So if it's not working, you have retention. So that means you have a problem with fluid overload. So mostly that's what happened. So the additional sodium increases water reabsorption and increases. So in the end result is that if the sodium absorption in your body is not working well, then your blood pressure will be high. Your blood pressure will be high. Now let's look at how potassium is absorbed in the kidney. In the serum, potassium levels stimulate the secretion of aldosterone. We had heard about aldosterone in the first one for the absorption of or the homeostasis of sodium, how sodium is being regulated in the kidneys. So it was from angiotensinogen 2, which is a potent vasoconstrictor that stimulates the secretion of aldosterone. Now we have seen that the serum potassium levels, if potassium is high in your body, if you keep taking a lot of bananas, it will increase your potassium. So if you have increased potassium in your body, it will stimulate the secretion of aldosterone. So aldosterone will be stimulated, and aldosterone will stimulate the distal convoluted tubule. I had mentioned that angiotensinogen 2 is a vasoconstrictor, and that one stimulates the aldosterone. So also stimulate the distal convoluted tubules, secrete potassium, and this action returns the serum potassium concentration to normal. So somebody will have to go and notify the other that potassium is high, and aldosterone is the one who does the regulation. So remember, we have angiotensinogen 1 and angiotensinogen 2. Angiotensinogen 2 is a vasoconstrictor, and that one stimulates aldosterone production. That has to do with sodium homeostasis in kidneys, how sodium is regulated in the kidneys. Now, potassium regulation in the kidney is pretty straightforward than this, that they didn't involve the angiotensinogen 1 and angiotensinogen 2. They just involve only aldosterone. It's only aldosterone that is secreted. So if aldosterone is secreted, aldosterone will also notify the distal convoluted tubules to secrete more potassium, and this action will return the serum potassium to its normal concentration. So it's like trying to balance and normalize everyone to stay within limits. Now, homeostasis of acidity, pH. So the blood pH, we know that when your pH is high, that's basic. If it's low, that's acidic.
When it's high, what happened?
Give me a minute. Okay, so we know that if potassium, if acidity from 7.3 the blood also have a pH. So the blood also have a pH. And if pH is, I'm coming. Okay, so we know that blood also have pH, and the pH of blood is being controlled by the kidneys as well. So the acidity, we know that if it's below 7, it's acidic. So the normal pH for arterial blood is 7.35 to 7.45. So a pH of less than 7.35 is acidic. So if the NCLEX present to you with a question that the patient arterial blood pH was 6, that means the patient blood is acidic. They say it was above that, it's going to be above 7.45, which is above the normal. So that one is considered basic. So pH is controlled by maintaining the concentration of buffer system, carbonic acid. I don't want to go into that one. Just understand the normal pH of blood. So the normal pH of blood is 7.35 to 7.45. And it's maintained by keeping the ratio of concentration of sodium bicarbonate to carbon dioxide constant at kidneys. So strong acids are neutralized by sodium bicarbonate to produce carbonic acid and the sodium salt of the strong acid. This process quickly restores the ratios and that's blood pH. So the kidneys also, just have an idea that the kidney also help regulate the pH of your blood. And the normal pH of your blood should be 7.35 to 7.45. For the NCLEX, you need to understand that. You need to know the normal pH of the blood. And you need to understand that the kidney also have a component that regulates the buffer system body. Now let's talk about the bladder. The bladder is a detrusor muscle. So when we talk about muscles, you understand it's a type of muscle and it's composed of smooth muscle and is distended during bladder filling and contract during retention. So if the bladder is full, it distends. But if the bladder if it's full, it distends and it contracts when the bladder is, I think this should be when the bladder is empty. So when the bladder is empty, it contracts. So the urethrovesicular sphincter prevents reflux of urine from the bladder to the ureters. That's the one that closes. So the moment it comes from the ureters inside the bladder and the bladder is full, it doesn't go back. It doesn't backflow into the tubules. When the pH is acidic, how can it be regulated? Oh, when the pH is acidic, I have the process here, I just didn't show it. So the concentration of carbonic acid is controlled by respiratory system. The concentration of sodium bicarbonate is controlled by the kidneys. So take note of this statement, carbonic acid controlled by respiratory system. This has to do with airway. This is where we have metabolic acidosis and alkalosis. So we have the metabolic aspect and we have the respiratory aspect of it. So
let me write it for you. Okay, go ahead.
Okay. So the pH of the blood is usually regulated through the buffer system. If you have ever read a buffer system where there is exchange of fluids in and out of a concentration gradient through the buffer system. So it's the buffer system that helps regulate the pH body to keep it normal. So if it's high, it's the buffer system. If it's the low one, it's the buffer system that helps in the regulation. The buffer system has to do with carbonic acid and sodium bicarbonate from the most important buffers for nucleic acid in the plasma. So this is metabolic process. metabolic process. So when the pH is low, we need the metabolic process in the buffer system to help keep it neutralized. So strong acids are being neutralized by sodium bicarbonate. So this one has to do with chemical equations. So when we have sodium bicarbonate like this one here, we write sodium bicarbonate, CO2. So this is the sodium bicarbonate I wrote. So this is where you will see them doing the chemistry, and then it has to balance. So all the components of sodium and carbon dioxide has to balance to be able to neutralize it and keep it normal. And this is done through the buffer system. So the buffer system will be a neutralizer to help neutralize the process and keep the blood normal limit. So the strong acid is neutralized by ammonia. So if you remember the buffer system back in school, you will know that we have ammonia in the formula as well. And ammonia or potassium salts, which is excreted from the adrenal glands. That's why I don't want to actually go into detail for that one, because it's going to call us to go back to look at our glands and the kind of hormones they all secrete. So understand that the buffer system, it has a component of it that it regulates the blood pH. That's why when you have your when your kidney is damaged, you will have all the problems. I'm going to show you. They are going to get there where the person's kidney is not working. You have complications from all your other body systems. So this pH regulation is a whole process on its own. For you to understand the chemical equations that are involved, we have ammonia or potassium salts that are involved. We have sodium bicarbonate, which help with neutralizing. And we have hydrogen ions, which does the neutralizing as well. So it's the hormone is secreted from the adrenal gland. So it's a long process. I don't want to dig into that because we'll never move further. Okay?
Okay.
Okay.
Yeah, so just have the understanding of the normal pH of blood and understand that the kidney also help regulate blood pH. That's the most important thing you need to know, especially for the ankles. But if you're an RN, you can go into the adrenal gland and then you try to study the buffer system as well. But for the LPN, you don't need to dig too much into it. You need to understand the buffer system, that blood pH, and you need to know the calculations to balance these equations. Now we have the urinary bladder. I have read about it before. The urinary bladder is a muscle. It's a detrusor muscle. And I told you that blood doesn't backflow, urine doesn't backflow into the tubules. So the moment the urine is formed, it fills into the bladder. So when the bladder is full, it's distended. When it's not full, it relaxes, it's empty, it contracts. So it's distended, and then is distended when full, and when it's not full, contracts. So there's the sphincter muscle I told you. The bladder capacity is 1 liter. So this is the normal bladder capacity for everybody. I don't have a liter measurement thing here. I would have shown you, but we know 1 liter of fluid. When we take a bag of normal saline, usually have the liter one. So I'm talking about using the liter one, not the 250 one or the 500 one. So use 1 bag. So the capacity of the urinary bladder, this is a normal urinary bladder. So the capacity of a normal one is 1 liter. Normal adult urine output is 1,500 ml per day of this quantity. So if you are doing the NCLEX and they're asking you about output and they want to know which one you follow up, and you have the patient making up to 20 or 2,000 cc per day. I told you the other day, cc is the same thing as milliliters. So the patient is making 2,000 milliliters per day. So for instance, a patient with new onset diabetes, they'll remember the question I gave you last week. So the patient can tell you that I make 22,500 cc of urine every day and measure it, that's too much urine. So the patient is having polyuria. That's where you need to take that symptom. So they will not tell you the symptom, they will rather describe the quantity of urine the patient is making for you to know whether it is normal or is abnormal. So the patient tells you, I make only 600 cc of urine. That's scanty urine. That means the patient is not producing enough urine. There's a problem somewhere in the kidney. Further studies needs to be done. So if you are teaching a patient about bladder and the patient tells you, oh, I make up to 800 cc of urine every day. Anytime I urinate, I measure it. But I don't think it's a problem. That means that's a statement you follow up on negative things, what is not right about the urinary bladder. So ideally, me and you, if your bladder is normal, you should be able to make 1,500 cc of urine in one day. Now let's talk about the prostate gland. So the prostate gland surrounds the male urethra. Around the male urethra. In the prostate gland, it contains ducts that open into the prostate portion of the urethra, and this one secretes alkaline portion of the seminal fluid, and this one that protects the sperm. So the alkaline protects the sperm. You have any question? I'm just talking about the structures of the urinary system for now. From there, I talk of the risk factor and the necessary diagnostic tests that will be done. Before I go to the diseases, I want you to take these lessons and understand them. Get the notes when we are done. So the risk factors that are associated with the renal system are what factors that will associate with your renal system to have a problem? Chemical or environmental toxins exposure, constant exposure to environmental toxins. If you remember, they keep talking about this asbestos thing. If you ever work somewhere and you have a cancer, you have this and this, you come and we'll help you claim and blah, blah, blah. So chemical exposure. So when you are teaching a patient and the patient mentioned to you, I'm telling you what NCLEX will present. So the patient mentioned to you, I used to work in a manufacturing company where we use chemicals to manufacture what and so many things. Then you want to be concerned about the renal system. It's one of the systems you'll be concerned about as well. Contact spots, diabetes, family history of renal diseases. So if the patient mentioned to you, my great-grandfather did have a renal problem, but I don't know why I just cannot pee these few days. I have problem urinating. I drink a lot of water, I'm not able to urinate still. Frequent urinary tract infection. So people who keep getting urinary tract infection often, they do get this. Ladies that get the intrauterine devices, they stand a risk for urinary tract infection as well. But people that get frequent of this, they are at risk for urinary system problems. Heart failure, people that have heart failure, we know about heart failure and accumulation of fluids already. High sodium diet, so when you keep eating too much of sodium. Hypertension, medication use, polycystic kidney diseases, trauma, lithiasis or nephrolithiasis. All these are risk factors that can give you a kidney problem. That's what this section means. So you need to understand. It's a lot of them, but try to understand that when the kidney is impacted, because it's supposed to filter the whole blood that is coming inside it and regulate the pH, regulate the sodium, and regulate potassium. Those are the three main things it does. So if the kidney is not able to regulate this, remember the blood will flow through your whole body with too much sodium, and it will flow through to your body with too much potassium. That's where every system of your body is affected. So when you have a kidney problem, it affects every part of your body because the kidney is supposed to take off excess of sodium, excess of potassium. So if the kidney is not taking all these excesses out, and it is accumulating and getting more and more, so you can imagine your whole blood is polluted. So that means your whole system, from head to toe, all body systems will be affected. We are going to get to that part where you see each effect the kidney has. When you have a kidney disease, each effect that will happen on each of your body systems. Let's talk of diagnostic tests. So that if a patient presents to you with kidney complaints, these are the diagnostic tests they do. Sometimes they have to do one test before they follow up to the other one. So the diagnostic test, I started with urinalysis, urine analysis. The UA. If you have ever done it, or if you have ever worked in the facility, this is UA, analysis. So I put the color of urine. So this should be the normal color of your urine. So this one is a lab result. We assume that it gave me urine, and when you TT, I went to run it on the machine. It come out, usually if you do out on a piece of paper like this, then you will see all this written on them. So if, let's say the ketones, if ketones is having a number on it, if the ketones are high, I'm suspecting dehydration. I'm suspecting dehydration. This whole component here, from color down to culture for microorganisms, it all gives you the reading for urine. So if I have any of these ones, or 2 or 3 of these ones altered, you can be diagnosed as having a urinary tract infection. So these are the normal ones I have put. So you want your osmolarity to be between this number. You want your urine specific gravity to be between here, 1.00. So if your urine specific gravity is not within the limit, there's a problem in your kidneys. So this is a normal urinalysis, urine analysis. We see the blood pH, the pH of the urine. So this is the pH of the urine that they expect it to have, from 4 to 8. Do we have any question on urinalysis or urine analysis?
What did you say? The pH is what? The urine? The urine?
Yeah, urine pH. This is not blood pH, urine pH.
Okay.
So this pH has to do with urine. So when you are sick and you go to hospital, they take urine from you and they go to normal results.
Okay.
Okay?
Yes.
Yeah, so this is a normal urine result that you will have. Now let's go. Renal function studies. So with renal function studies, the normal values, you expect to get normal. These are the normal values for a renal function test. So when you do a renal function test, okay, when you do a renal function test, below are the normal values. You expect the BUN fall between this 10 to 20. Mostly they'll use that number on the exam, 10 to 20. So you expect the blood urea nitrogen to fall between this. So if this one is elevated, there's a problem with kidney function. Creatinine. So when they run the patient's blood work, this one usually is done through blood. So when they do the patient, I think CMP is full, or CBC, one of them. I don't remember, but I'm going to get that result for you. When they run it and they see the BUN, and the BUN is elevated, then they come to see creatinine. Creatinine too is elevated. Then they suspect urinary system impairment. So these two results alone can make them detain a patient because something is not right with your kidneys. This is the kidney function test. So if your creatinine and your BUN is not in order, but these are the normal ones you need to know for the NCLEX. So your BUN or your creatinine ratio should be 6 to 25. That's the ratio. But the serum creatinine level should be 0.6 to 1 for males and 0.5 to 1.1 for females. So we have the serum creatinine for male and for female. So take values. When this is presented to you, a patient can come to you and come and show you a result of her labs, and they expect you to take an action from there. What will be the next step? So you need to know the right one, the correct information, then you go and compare it. Now, determination of serum creatinine. How is the serum creatinine here determined? A test that measures the amount of creatinine in your serum, that is in the blood. They do this through the blood. Creatinine is an end product of protein and muscle metabolism. So I was telling you about metabolism, like metabolic acidosis, metabolic alkalosis, which is different from respiratory system alkalosis and acidosis. So metabolic alkalosis, the end product of muscle metabolism is creatinine. Now, you determination of blood urea nitrogen levels, a serum test that measures the amount of nitrogenous urea. So of protein metabolism in the liver. Urea is a byproduct of protein when protein is broken down in your liver. So your liver is supposed to metabolize protein. So if your liver metabolizes protein, the end product is urea, which is not a wanted substance for your body. It's supposed to be excreted. So it's a byproduct. Urinalysis, I had explained that already in the picture. That picture was supposed to come here, but we have that already. It's a urine test for evaluation of the renal disease. So you use that one to diagnose UTIs and other stuff. If there's bleeding, we saw that there was a blood component in it. Let me see. You see hemoglobin? And see if there's blood in your urine. It will state it clearly. If there's glucose in your urine, if there's bilirubin in your urine, and then if there's microorganisms, if there's bacteria in your urine, then they can give you a diagnosis and follow-up treatment. So the intervention, so for a patient to go for urinalysis is just to have urine collection. So you have to do a clean catch sample. Sometimes you have to do the 24-hour urine sample collection. And that you check the laboratory, like the 24-hour urine sample collection. This is the procedure. You have to check about specific instruction for the client following, such as the diet and the medication. So if the client tells you, I take isoniazid, you know that is going to change the urine color. So you don't need to be scared. If the client tells you, I take antibiotic, you're going to understand. So we have some medications that will change the color of the urine. You want to advise the patient. So dietary instructions, you instruct the client about the urine collection process. So at the start of the time, you instruct the client to void and discard that sample. So you tell the client to discard the first sample and collect urine from 24 hours. So if the nurse for this client, they want you to teach the patient and they give you a drag and drop options. These are the instructions you want to follow. So first of all, you want to collect information, that is assessment. Gather information about the urine sample. So you tell the patient, do you take any medication? How is your daily diet? How do you diet? Take any medication? Gather that information. Then you tell the patient the process you are going to use to have them collect the urine. So I'm going to have you PP right now. And then from after when you start to PP that one out, the first urine, we throw it out. But from that time until tomorrow, the same time, we are not going to throw that urine. We are going to be collecting it so that it. So the 24-hour urine collection, you keep the urine specimen on ice or refrigerator and check with the laboratory regarding adding a preservative to the specimen during the collection process. So each time the patient has to urinate, you have told the patient what to do. The patient has understanding. So if you tell the patient that this process that you have taken all your assessment information first and you have explained the procedure to the patient needs to PP the first one and throw out. And then the patient come back to you. After the patient PP first and threw it out. Second, third, the fourth one, the patient tells you, can I throw this urine? I usually throw this urine out before I collect the next one. That's wrong information. That's why you need to come back and teach the patient the procedure. So that's what NCLEX will catch you. So take notice of the wording. When they mention the words, you want to be able to take notice of those kind of words. Now, specific gravity determination. How do we determine the urine specific gravity? That's the procedure I put there. Give me 1 second. Okay, I was talking to Emilia. I see she didn't join. I'm not sure if she's having trouble joining. So urine specific gravity determination. A urine test, this is a urine test that measures the ability of the kidneys to concentrate urine. The ability of the kidneys to concentrate urine. So that is what urine specific gravity is, the ability. Oh, I don't see. Okay. Okay. Gertrude, welcome back. Now we have the next test, that is urine culture and sensitivity testing. Urine culture and sensitivity testing. So if a patient has a 24-hour urine collection, the first urine should be thrown out. But during the 24 hours, all the urine collected. Yes. So you want to collect all the urine. So if I PP9, I throw it out, you mark the time. So right now it's 8:19, so I put the time down. Tomorrow by 8:19 p.m., any urine I urinate within this, that is collected. So you save it in the fridge and you speak to the lab technician to see if they want you to add any additive to it. That's the procedure for 24-hour urine collection. So you educate the patient. But before you educate the patient, you have to assess. So assessment is the questions you ask the patient. Do you take any medication? Do you have any dietary issues? What do you take, like just medication and diet? Then you educate them and you encourage them to take water, and that's it. So any urine collected is used for the studies. Now the urine sensitivity, urine culture and sensitivity. Test macro determines the specific antibiotic to treat the existing problem. So this is a test that you use to determine which particular organism is it that is affecting your urinary system. Then you also use that to determine which antibiotic will I be able to use to tackle this. Could it be a yeast infection? If it is a yeast infection, antibiotic is going to tackle the infection. Usually they will give fluconazole, which is an antibacterial medication or antiviral inhibitor something. We'll get to that. We have creatinine test. Creatinine test is a test that evaluates how well the kidneys remove creatinine from the blood, and it is an estimate of glomerular filtration rate. It estimates the glomerular filtration rate. So that's what creatinine test is. And it's also done in the blood sample. It's done through blood test and timed urine specimen. So we can do the creatinine test from blood sample and urine. So I put this yellow note here, like I tell you, those that I highlight them yellow, take notice of them, and like to take information like that and twist it as a question. So I said the creatinine clearance test provide the best estimate of the glomerular filtration rate. The normal glomerular filtration rate is 125 ml per minute in young adults. So for every 1 minute in a young adult, your glomerulus filters 120 of your blood. to make urine. So by age 65 years, the glomerular filtration rate is approximately 65 cc per minute. That's reduced. So as you age, your glomerular filtration rate or your glomerular function is reducing, just like your other body organs are reducing in function. Everybody starts reducing in function. So if you are a young adult, you have 125 cc every 1 minute. Your glomerular is able to filtrate up to 125 cc of urine from your kidneys. Now, one is kidney, ureter, and bladder radiography. This is just X-ray. You do an X-ray of your kidneys. So this is an X-ray of your kidney, your ureters, and your urinary bladder. So we know the procedure for X-ray already. This is want to ask the patient is usually used to determine if the patient has any renal calculi or any kidney stones. So this, they just have you go for an X-ray. They tell you it's a pelvic X-ray, but it's supposed to study your kidneys, your ureters, and your bladder, so that they see if there's a stone in the ureters or if there's a kidney stone. I have a picture of a kidney stone. Now we have the bladder ultrasound. Bladder ultrasound is just scanning. They do an ultrasound, a scan of your bladder. So it's non-invasive. The radiography is X-ray they do of your kidneys. It's radiations. It's radiations, but the ultrasound is scanning. That one is more invasive. It's just to use the ultrasound. They use a transmission gel to view your kidneys. Your bladder. We have the intravenous urography. Remember, we had the intravenous pylography in one of our questions that we had read. So intravenous urography. This one is also an X-ray in which an intravenous injection of a radio-opaque dye is used. So anytime you see intravenous urography or intravenous something, you should know that they're injecting something into the vein, within the vein. So inside the vein, they inject a dye to it, and they visualize the renal system as venous urography. And the next one is the yellow note I put. I said contrast dye is potentially damaging to the kidneys. Yes, so this is what another thing I'm going to explain to you. Anytime a patient is taking contrast, or anytime a patient is going for a procedure and it involves contrast, contrast is damaging to the kidney. It could be abdominal CT scan, abdominal CAT scan. So far as they are using a radio opaque dye, they're using a contrast, it is damaging to the kidney. They will always look for the urine function. They will always wait for creatinine to be back. They have to know the creatinine. Is the patient kidney function normal? So if the kidney functions are good, then they have you do it. But the other thing too is that they hydrate you. They make sure you drink a lot of fluids. When we start talking about the kidney examinations and all those tests, you see that patients need to always drink a lot of fluids. And that fluid should usually not be less than 1,000 cc or 1 liter. So contrast dye is potentially damaging to kidneys. The risk is greater in older clients and those experiencing dehydration. So the contrast dye used in IV urography may be nephrotoxic and therefore encourage fluid increase unless fluid is contraindicated and you monitor the patient's urine output. It is also essential that the pre-procedure BUN, blood urea nitrogen, and the creatinine levels are assessed on any client that is going for a procedure where dye might be injected. That's what I just explained. So the primary care provider will institute precautionary measures to prevent acute kidney injury and use smaller amounts of dye. So if you know the patient, the dye, they also prescribe it. It's just like medication, they will prescribe it. So if you do the patient kidney function, the blood urea nitrogen and the creatinine levels, and they are off, they are not good, they are low, that means the kidney function is reduced. So they will use a small amount of the dye so that they don't further damage the kidneys. But they are also going to encourage hydration. So patients who are even dehydrated, they will get more hydration before they go for any contrast dye procedure. Do we have a question on that one? Now let's talk about renography. That's the kidney scan. I talked about the bladder ultrasound. Now kidney scan. So this one is an IV injection of radio opaque for visualizing image of renal blood flow, glomerular filtration, tubular function, and excretion. So just like I explained with the contrast or radio opaque dye, the same thing you are going to take notice of. So the intervention is for you to monitor the blood urea nitrogen level and the creatinine. And then you notify the provider. If the patient's levels are low, you notify the provider. They might order a lesser dose of the medication. Now, renal biopsy is insertion of a needle into the kidney to obtain a sample for tissue for examination, which is usually done. So if they need a tissue from your kidney to study it, they'll do renal biopsy. Cytoscopy and biopsy of the bladder. So this one is the bladder mucosa that is examined for inflammation, calculi, stones, or tumors by means of a cytoscope. They use something like a scope and then they view it. And they also do a biopsy to get sample from your bladder. That's what that is. So pre-procedure, every procedure, you always want to know the vital signs. So you always want to have the patient baseline of urinary studies. So all these procedures, you want to know the intervention. The intervention is to make sure you have the vital signs, you have the patient's urine function baseline, you have the initial labs. That's all what it means here. So you withhold food and fluid as prescribed. So interventions during the procedure, you want to think about positioning. So if a patient is going for renal biopsy, they do like to dig into that for the ankles. So renal biopsy, they have to go into the kidneys and cut a sample out for studies. So you have done your pre-procedure intervention, which is assessing vital signs, getting the patient baseline results. And then you verify informed consent. So this is an invasive procedure. So you need a written informed consent signed by the patient. So the doctor is supposed to collect the informed consent, or doctor is supposed to explain the procedure to the patient. But if you go to the patient to prepare the patient for the procedure, and the patient asks you a question, or the patient passes a comment, that you should be able to understand what the procedure to is. And then if the patient needs further teaching, you have to follow up with the provider. The patient did not understand the procedure. Can you explain to the patient? Or you can also do a follow-up teaching for the anklets, for the LPM, you do a follow-up teaching. That's why they require you to also know what it is, even though you are not going to do initial assessment, but you also need to know what the procedure is to tell the patient. You teach as well. You do follow-up teaching as well. If the patient is saying what is wrong about the procedure, you should know. Now, positioning after the procedure or during the procedure. So when the patient is at the procedure for the biopsy, you position the client in a prone position with a pillow under the abdomen and shoulders. So I want you to take note of this positioning. That's the only thing you have for the intervention. During the procedure intervention is how you position the patient. So the patient should be prone, should be placed in a prone position with a pillow under the abdomen and shoulders. Can somebody show me the prone position? What is the prone position for a patient? So your kidney biopsy procedure, you should be on a prone position with a pillow under your abdomen. and your shoulders. So you put yourself on a pillow like this, and then your stomach is all covered. So it's face down. That's prone position. Now let's look at post-procedure. After the procedure, you monitor the vital signs, especially hypotension, which indicate bleeding. You provide pressure to the biopsy site for 30 minutes as prescribed. Listen, this is a standard order, okay? So this one, NCLEX will ask you, they want to know how many minutes. So the patient come back from the kidney biopsy, and you stand there and you put your hands on the patient. Is like, why do you have to stand for me? Do you have to stand by me for more than 10 minutes? Because you've been standing here for a couple of minutes. I just cannot estimate how long you've been here. Why do you have to stand? And why are you even putting pressure on my abdomen? Has the procedure not finished? You are worried for the risk of bleeding. So you put pressure on the site for 30 minutes. You stay with the patient and you put pressure on the site for 30 minutes to prevent bleeding. That's what NCLEX will tell you. If you work on the floor and you have seen it, don't say nurses don't have time to do it. They put tape and they walk out. No, you're supposed to stay with the patient for 30 minutes. Put your hand on it. That's what NCLEX wants you to do. Then you monitor blood levels and then you check the hematocrit for if there's a decrease, you suspect bleeding. Then you place the client on a strict bed rest in supine position with a back roll for additional support for 2 to 6 hours after biopsy. So take notice of intra-procedure intervention, and then the positioning you maintain during the procedure and the position the patient maintain after procedure. So after the procedure, the patient, you press the area for 30 minutes, and then you have the patient, you put a roll to the patient's back and have the patient wait 2 to 6 hours after the procedure, strict bed rest. Okay? Then you encourage intake of fluid. I have already told you, most of the kidney procedures, they will want to know how much fluid. Don't choose any answer option that is less than 1 liter. Anytime they are encouraging fluid, it should be at least over 1 liter, and mostly 1.5 liter and above is recommended. 1.5 liter, 2 liters are all recommended. So 2000 cc or 2000 ml is equal to 1 liter. That's why you need to know your conversions, you know. I had told you that. So if you have 1,500 is 1.5 liter, 1.5 liter of fluid. So the big bag of normal saline plus 500 is 1,500 ml. That's 1.5 liter. So you want to instruct the client to avoid heavy lifting and strenuous activity for 1 to 2 weeks. So take notice of the education. The client education is so much important to me. And because I know that is what you are going to do on the NCLEX. If you cannot educate patients on the NCLEX, you don't pass it. If you cannot tell them correct information about their diagnosis and their treatment procedures and their treatment plans, you cannot pass this NCLEX. So guys, you need to sit up and understand how you are going to teach patients, how you are going to respond to patients' questions when they come to you and they ask you, because the patient doesn't know you don't understand. They know before you become a professional, you would have had enough training to be able to tell them the truth. So you instruct the client to notify physician or provider if either a temperature greater than 100 degrees or hematuria, or that's blood in urine, occurs for the first 24 hours. So they just tampered with the kidney. So if they just tampered with your kidney, you are worried that you might bleed from the kidneys. So do we have any questions? So for the first 24 hours, you want to tell the patient, if you urinate and you see blood in your urine, you have to quickly report. After you have had a kidney biopsy, they cut a portion of your blood. So within the 24 hours, we don't want blood in your urine. If you have it, you have to report it. That's part of your teaching. So your post-procedure interventions will involve a lot of teachings, a lot of things to note. You don't want the patient to develop a fever within this time. So a temperature that is above 100, tell them to report it. And then within 2 weeks, 1 to 2 weeks, no strenuous exercise, no going to gym. So the patient tells you, oh, I like to go to gym every Wednesday, and today is Monday. I just had this procedure. Am I still able to continue my gym activities? You have to teach them that is 1 to 2 weeks. They have to wait. So after 2 weeks, they can go back to gym activities. You can't go and strain your muscles. And then 30 minutes, you put the pressure and you wait. Then you maintain strict bed rest for 6 hours immediately after the procedure. Do we have any question? I'm going to, the next thing we are supposed to move on is to go to acute kidney injury. So I'm going to move further and I'm going to stop the lesson here. Do we have any questions? Do we have any questions on this?
I don't have any patience.
Do you understand what I'm doing at all? All of you, your videos are off.
Not me.
I can see you.
I'm seeing you.
I know all of you are seeing me, but I can't see anybody.
Maria.
Yeah, I wish I could.
No.
So
Maria.
and I want to know who is dozing off and who is actually listening to me, because I don't want to be wasting my time most often. It's fair to me to be able to see you and know that you are participating, because when I ask any questions, like nobody answers, nobody say I understand, I don't understand. I have to repeat it and repeat it. So let's make it more interactive than it is now. Let's ask questions. Let's make discussions interesting. I have explained about the kidney, the various tests that they do with the kidney. So if you have a kidney problem, the kind of test that they will do for you. So if they will do the test for you, what are those diagnostic testing they do? So these are the diagnostic testing they do. I'm just going to mention that. I'm not going to talk about it. I just finished talking about it. So they will do urinalysis for you, urine analysis. They will do renal function test. Are you guys writing down? You're not even taking notes. You're just sitting down. Patience. Look like you're even sleeping. So write them down. So they will do, for a client with kidney problems, these are the tests they will do. They may not do all the tests for one kidney problem. So if you do urinalysis and you realize that it's UTI, you start treating it. So urinalysis is kidney function test. We have renal function. So we do renal function tests or renal function studies. Then the next test they will do is, remember urinalysis is urine analysis. That's the other name of it. Then we have the 24-hour urine collection. Then we have the kidney radiography. Kidney radiography, that's kidney x-ray. So they do x-ray for the kidneys, the ureters, and the bladder. They do an x-ray, kidney radiography. Gertrude, are you writing down? Gertrude? Hello? I hope she's not sleeping. So they do the kidney radiography. So the next test they do for the kidney problems is bladder ultrasonography, bladder ultrasound, or bladder scan. Bladder ultrasonography, that's the bladder scan. Then we do the intravenous urography. Intravenous urography. This, they use a contrast. They use a dye. And anytime you hear of a dye in kidney test, you know that you have to hydrate your patient. You have to give the patient a lot of fluids. And I told you to take notes. Anything I highlight in yellow or in green, you take notes. So I said for a patient that is taking any procedure with a dye, It can be abdominal CAT scan. You have abdominal pain, they are doing CT scan. They are going to give you a lot of water to drink, and they are going to determine how well your kidney work. They are going to get the BUN and the creatinine. Then they know how your kidney work first before they do the bladder, before they give it the contrast. And they are going to give a lot of fluid. They are going to hydrate you. Then we have the renography. That's the kidney scan. Renography, kidney scan, is also involving the use of radioisotopic injection. They also use another contrast. So that's the radiography. They do the scan for your kidneys. We have the cytoscope and biopsy of the bladder. They use a cytoscope to view inside your bladder, and then they do a biopsy. They cut a tissue portion of your urinary bladder. We have the renal biopsy. That's the one I just explained. That's the kidney biopsy. They go into your kidneys and they portion of studies. So with that one, you have a pre-procedure intervention and you have an intra-procedure intervention. The intra-procedure intervention, you are concerned about the positioning of the patient. How you position the patient for the procedure is very necessary. And of course, within the procedure, you continue monitoring the patient vital signs, even though that is not here, but you need to continue monitoring the patient. And then post-procedure intervention, you want to put pressure to the site. You want to put pressure on the site of the biopsy. So if it's the left kidney they went into, you have to position the patient on the right side. Don't position the patient on the left side because the patient is going to bleed more. So remember your positioning. So if the patient has a kidney biopsy on the right-hand side, you don't position the patient on the right-hand side. After the procedure, you position the patient on the left-hand side, and you put pressure on the site for at least 30 minutes before you help stop bleeding. And the patient have the kidney biopsy too. You want to have the patient stay in bed, strict bed rest for 2 to 6 hours after the procedure, 2 to 6 hours after the procedure. And then the other thing you want to tell the patient is to encourage fluid intake. Encourage fluid intake. I said 1 liter is equal to 1,000 ml. 1 liter is equal to 1,000 ml. So 1.5 is 1 liter and 500 cc. So take notice of your conversions. So if they put the ml, you know that 2,000 is 2 liters. So from 1.5 to 2 liters for the patient to drink. Sometimes the patient may not be able to drink orally. You put it through an IV. So take note of that. The other thing you want to also instruct the patient is to avoid activities. No strenuous activities, no lifting, no heavy stuff. 1 to 2 weeks, no going to gym. They need to relax, take it easy, and have their kidneys heal after the biopsy. And you also want to instruct the patient to report any fever. And finally, 24 hours, if there is a fever, you tell them to report. 24 hours, if there is blood in their urine, you tell them to report. So anytime after the procedure until 24, or anytime there is a fever after the procedure, they should report it. But within the first 24 hours, if they notice urine, they should report it to you. That is specific of renal biopsy or kidney biopsy, when they cut a little bit tissue of the kidney for studies. Any question? Because I'm going to stop here. We still didn't go into that topic because we had to discuss our 7 questions. That took us an hour. That's why I don't like to discuss the questions, but I know it's also necessary. So sometimes I put that in for us to discuss, so I know where you are. But with those questions, it tells me you didn't learn them. You didn't read, please. If you want, I can send you back the material I can send you back the videos and you go over them. You need to read them because we are moving forward and we are not coming back to it. I don't want you to just come to this class and waste your time. I want it to make sense to you. That's why I keep telling you, if something doesn't make sense to you, you have to let me know because it's not worth doing it over and over. It's not worth going to this exam, coming back, and every time all your mind is, I need to be studying, I need to be studying. We are growing, we having responsibilities, we need to move on with our lives. So we need to, when you start to do the studying, concentrate on it, get it done, pass this exam and get it out of your way. And this is what you need to know. So if you walk into that exams and you don't know that if a patient has a kidney biopsy, if a patient has a kidney biopsy, you have to put pressure on the site for at least 30 minutes after the procedure, or you have to position the patient during the procedure, prone position with the pillow under the chest or and the shoulders. How will you answer a question if the patient tells you the wrong positioning on the ankles? You will pick the wrong answer. So that is why I keep pushing you to study this content. There is no way the exams will pass by you if you understand this content, if you take notice of these procedures, and you just need to understand them. There is no way you enter there and you read a question and you know about biopsy, kidney biopsy, and you will not understand, you will not pick the most immediate thing. So you know that the most immediate thing after the procedure will be bleeding. That's why you put the pressure for 30 minutes. And that's the risk you want to prevent. So there is no way you have this content in your mind and on your fingertips and you go and come back. Trust me, it has worked. I have worked with people who have gone severally. Somebody finished 2012 and the person keep going and coming. I told her, I said, let's do this. Let's go back to the book. Let's study. Stop jumping. There's no jumping steps in the studies or in the process of NCLEX. When you think you can jump cardiovascular system and go and answer questions and pass, you will not make it. I read a research survey they did about UWorld, Kaplan, HESI, ATI, all those reviews that give a lot of questions. And none of them got up to 40% pass rate for students who focus mainly on that. Those who pass, all they will tell you is that I had to go back to my contents. I had to know the nursing content. So if you keep answering questions, or if your mind is that when you start studying, you are just going to learn how to answer these questions, and you don't understand that when you are teaching a client, the patient can tell you wrong information, or after the patient have signed the consent form, the patient can still say what is outside of the procedure. You yourself don't know what kidney biopsy is. If you don't know that they go inside the kidney and they cut it, how will you educate this patient? How will you do a follow-up teaching? How will you know that vitamin K is an antagonist for anticoagulants? So how will you know that if I am taking anticoagulant to help thin my blood, I shouldn't be taking vitamin K because it will inhibit its function. It will not make it work effectively. I'll be stopping the work of the anticoagulant medication. How will you give it? How will you explain to the patient? So this is what NCLEX wants you to do. I'm leaving the ball in your court. I am doing my best, and I know you are also doing your best. But let's do our best right. My best will not be right if you don't do your best right. It's not going to match. So don't leave the pressure on me alone, because I do a lot of work just to get you the information. You have to study them. And when you get the content, if I am fully convinced that you have this content, we can come on the line and we talk only of questions and we get out. I don't mind. But for now, I think we need to study a lot of the content. For some of us, we need to do a lot of studying of the content. When you understand the content, go and practice it with questions. That was the purpose of the 7 questions, is to have you practice the content we learned into the questions. So that's how they present to you. Any question? Because we are going to end our lesson.
Shepherd,
Yes, ma'am.
that means if you are bleeding, you don't have to take vitamin K, right?
If you are bleeding,
Yes,
you have to take vitamin K.
you have to take vitamin K.
Because vitamin K will help stop the bleeding. It will help stop bleeding. But if you are taking a blood thinner, that means you are at risk for blood clots. So you are taking the blood thinner to make your blood thin. You are taking anticoagulant to prevent any coagulation or any clotting in your blood. Do you understand? So if you are taking this medication to prevent blood clots, why, if you are not bleeding, if you don't have an issue, you keep taking the Eliquis and you don't have any bruises on your skin, you don't have any bleeding issues, why do you take vitamin K? Take vitamin K, that means the medication you are taking to help your blood, you are creating more clotting factors in your body. So it's not going to work. They are like antagonists. So if you take anticoagulants or you take heparin and you start bleeding, then they give you vitamin K to stop the bleeding. You understand? But you are taking heparin, the heparin is working all right. You don't have any blood clot issue. Your blood is flowing good, but you keep eating green leafy vegetable every week. That is more vitamin K. Your blood will become thicker again and you have clot. You'll be taking the heparin, but the heparin will not work. The anticoagulant will not work because you are taking an antidote that is preventing it from working. So you still have issue with clotting.
Okay.
Yeah?
Okay.
Yeah. Any question, Beverly?
No, I don't have any.
Gertrude, are you on or you are sleeping? No, it's late. I know it's late in Ghana. Gertrude is joining us from Ghana. So I know it's very late in Ghana. Okay. So if there is no question, I did send you some information today. I'm going to send you this one on, I'm going to give you the video so that you repeat the video. Thursday, when we go into the disease conditions, we are now moving into the disease conditions for the renal system. So we have explained the diagnostic test that will be done. So when we come back, we are not continuing where we are stopping today. So on Thursday, we are moving straight to acute kidney injury. When we go before we go into the disease conditions, I want you guys to go over this video again. Go over this video lesson and understand the video lesson so that when we come back next time, you can go over the first one that I spoke about, the anatomy and the urine formation, and you can go over this one where I discussed the diagnostic test that will be done with a patient who has kidney issues. So when you know the two, the next time we are continuing with the diseases that affects kidneys. So we are going to talk about all the diseases that will fall under kidneys, except bladder cancer. Bladder cancer, I didn't capture that one. I intentionally didn't because that falls under cancers. So except for bladder cancer, and I've always mentioned if you have your white blood cells that are low, neutropenia, you're concerned for cancer issues. Elevated white blood cells, you are concerned about infection. So I didn't capture bladder cancer, but all diseases that affect the kidney, I have captured it. So I want you to go over this video again. On Thursday, when we start tackling the disease conditions, I'll send you that video again. I want you to be repeating it so that you keep the information once and for all. As we move further, you are moving with us. But if you don't repeat these things, if you don't go it back and forth. So whilst we are somewhere far talking about prioritization of a patient with kidney biopsy, you will now be starting what a kidney biopsy is. I want you to be on track with all of us. Do I make sense?
Yeah.
Okay. So if that makes sense to everybody, we are going to hang up here. Thank you so much.
When are we submitting the questions?
It's due on Sunday.
Sunday.
And listen, I have put it on the heading. It's not just the questions I want you to answer. I don't want you to get 75 over 75 and you don't understand why you got that. If you read each question, like the way I did the analysis, ask yourself, are they talking about? And do I know this topic? That's why I give it to you Monday through Sunday. If you'll be late on Sunday, you can submit it on Monday before our class. It's fine. But just make sure you go over the topics. It's another study material, you know. It's not timed. I didn't time you. I'm going to put the timing in the website, but I haven't done that yet. But this one is not timed. It's for you to have time and go over it. If you're having trouble opening it as a PDF attachment, let me know. I will send it to you on WhatsApp attachment so that you can open it and just read it. The same way you type the answers for me, I don't mind if you type it like that. Sometimes the writing, I don't want you to waste your time using a pen to type question number 1. Patient will say so, so, and so, and so, and you write it all this long statement. Don't do that. Just make sure if you cannot use Microsoft Word to highlight the answers, it's the easiest to do, which I would so much love it if you